Hi and good evening, ladies and gentlemen, colleagues and friends. Welcome to another evening of a webinar session from the Sydney Prosthodontic Group. And tonight we'll be talking with you on the topic of improving dental impressions. Joining me this evening, as always, are my friends and colleagues, starting from my right-hand side here, Dr. Johnson Chou.
Hi, everyone.
Dr. Zoe Potres.
Hello, how are you?
And Dr. Agnes.
Hello.
As always, the team here will provide you with a live and interactive session on this particular topic. Tonight's session will run for approximately 2 hours, and given it's live and interactive, that means that you can key in your questions. So just scroll down to the screen towards the bottom and enter your question. I'll try my very best to push these questions across to the entire team to try to answer as many questions as we can. To receive your CPD certificate, please don't forget to also scroll down to the bottom of the screen to enter your name and email address, because without doing that, you won't be getting your certificate. So please don't forget to do that. Just a couple of disclaimer. All the presenters here are COVID negative. We do get ourselves bi-weekly checked, and also we're fully vaccinated. And all information presented this evening are for the opinion, our own expert opinion, so please do use these information at your own discretion. Tonight's session will not be possible without our sponsors, starting from Noble Biocare. They've been with me for a long time, sponsoring me and also these sessions for, I think for just a little bit over 10 years. I have been heavily involved in doing the Noble Biocare mentorship program, which is this implant program in the 4-module basis, covering from the most basic in introducing the implant topic, right up including the surgical aspect, restorative aspect, and a full arch component. So right from the beginning of introduction to the most complex. So it's quite well suited for people of any experience groups or levels, and this program will start again this year in May. So for the ones that's interested in furthering your dental implant journey and education, this will be quite a suitable program for you. So all you have to do is just search those words in Google, and I'm sure that will take you to the right link. Our second sponsor, Credible. As we all know, Sandy and Teresa, who's been serving our industry for a long time. I'm sure we all know these people, and recently perhaps even see them at ADX. Now perhaps once again is an excellent opportunity to take up another finance deal, given that the low interest rate that we still have. Next, we have Chou. We all know that Chou is a household name when it comes to endodontic and restorative materials. This evening on the topic of dental impressions, we'll be certainly talking about a number of the impressions from Chou and other companies to give you a showcase of a whole range of the options that's available. And last but not the least, Experian Insurance Services. Experian has been looking after the dental industry for more than 15 years, and they've been taking care of over 1,000 dentists. Over the years, they've received over $100 million in payout, which is quite impressive for that many of dentists. And they are also, if you want to win a box of Hayes chocolates, you can go into a lucky draw. So some of you guys may already received an email with a QR code. If not, you can use that QR code on screen. Simply scan the code, answer a couple of questions to be in the draw. And I'll remind everyone again as part of the program goes on. And for the participants that's joining us for the first time this evening, just a little bit about ourselves. Sydney Prosthodontic Group is located in Chatswood, Sydney, offering a full range of surgical and restorative prosthodontic services. Me and the team here have been providing you with online education, or previously before COVID, it was all face-to-face education. And I think as the COVID is becoming more manageable, we will return back to face-to-face seminars again. But for now, for the next perhaps 1 or 2, it may still be webinar based, but eventually I think face-to-face is still going to bring terrific value to all of us. But we're proud to present all the information that we have learned over the years as a result of treating your patients. And we simply want to share what we've learned. And that's what these sessions are for, to thank you, our referring dentists, for your trust in us and for your support of our group. And we are eternally grateful of that. At Sydney Prosthodontic Group, we're certainly about relationship building. So if there's anything that we could be of service for, whether it is treating your patients or helping you out with whatever problems and concerns that you may have, collectively, with our collective resources, I'm sure we're able to help you and your patients out to our best of our abilities. So let's get a move on to tonight's topic of taking dental impressions. In this particular topic, we'll be covering a wide range of subtopics, including impressions for teeth, for implants, and for soft tissue for our dentures. And last but not the least, we're also going to be covering the digital scanning as well, which is becoming more and more popular in the dental field. And so we'll be sharing what are their limitations and what the research are indicating. So we all know how important it is to take a good impression, and we all should know what a good teeth impression should look like. So perhaps we'll start off this evening, talk about teeth-borne impressions for crown and bridges. So Agnes, if we could start off with you, if you don't mind, share with us what is a good impression is about and how do we go about obtaining one?
Sure. Okay, so let's start with talking about crown and bridge impressions. So many times when we want to take these impressions, of course, it is for the purpose of fabricating your final restoration. And that means we're going to get a model and some die out of these impressions. And that is why with this impression, we want to capture high details. And often the area of interest that we capture is a static passive area. Now, if we look at the slide we have before you, you can actually see a beautiful smooth margin that's well defined, and that is also part of the highlight, is that your finishing preparation, the outline ideally should be nice and smooth and well defined. The main message throughout this segment of the program, the key to getting an ideal impression, is that as the operator, you must be able to visualize what you're trying to capture. If you cannot visualize what you're trying to capture with your eyes, then you won't be able to capture it with the material that you use. So many a times when we are dealing with tooth-borne restorations, it's often nice and easy if we have supragingival margin. But take this case, for example, where the patient with her central crowns are after a remake because of the gingival erythema and the marginal irritations from the crown we want to make an improvement of. Then not only are we going to be working at a subgingival level, but ensuring that we have a nice emergence profile and a finishing outcome, good marginal adaptation are all the key to the success and management of this case. And that is why being able to manage your impression technique and materials to have this capture is very important. So when we are looking at the impression, sometimes it's very hard to appreciate what comes out of it, which is the model, the positive of what we have taken the negatives of. And in this scenario, what you are able to see is that within this margin that we're trying to capture, a lot of us, when we critique our impression materials, as the material have said, and you've uncovered it and you look at it, a lot of us are tuned to try and see whether we've captured beyond the margin from a vertical perspective. But in reality, once this impression is being poured to a model, a die has to be made out of it so that the technician can contour the crown. So when we're dealing with that, what we actually want to capture is not just a vertical distance beyond the marginal preparation, but also have a comfortable horizontal space to allow the placement of this burr as the ceramist trim the dies, and not just a safety margin to work with, but also a clarity of where the marginal finish may be. It is only when the die is trimmed and you have something like that is before you, that there is actually a distance and the contour of how the tooth or the root emerge to the rest of your restoration, that you're able to expect your laboratory colleague to be able to generate something that you wish for and can be delivered clinically. So that's why, in this particular, going back to this particular lovely impression that you see, you can see that vertical and horizontal area in the soft tissue, the sulcular space, is being captured very well and well defined in this particular impression. So therefore then when we look at the crown restoration, you would then be able to see that again, that this finishing outline coming from below the tooth around the cervical area can have that nice smooth emergence profile and good marginal adaptation that one can expect from the die. And to ensure that it goes to a nice proximal contour, the marginal ridges, etc., it can have that finishing outcome. Now, when sometimes we look down with the impression that we capture, in areas, you may be able to see, oh, look, I can capture, that's my shoulder area. I'm looking around, checking my impression. I think I've got my margins. There's no bubbles. But here, some of the areas, to be honest, once it goes into a model, is actually now very hard to see. I'm going to turn the spotlight off in a moment. Here you go. You can see a nice shoulder. But really the chamfer margin, even though if we've captured the vertical, because there's not much horizontal distance and there's those slight blemishes, it is very hard now to expect our ceramists to be able to trim a die and predict where the margin is without any horizontal defects. So this is a particular case I will walk you through where patients come in and it's got very poor margins that we want to replace the crowns for her. We have to first remove the crowns and extend the margin apically to where we would like the finishing lines to be. We would apply a retraction cord, a 000 retraction cord, so that we can allow the finishing of the preparation more safely and apicalizing it as much as we can for improved furrow. Are we able to go to the next slide? Just having a bit of technical. There we go. And so here you can see that on this occlusal view, we have now apicalized the margin to where we would like it to be with our 000 cord at the base. And then so from here, once we're happy with the smoothness of the margin and the preparation, we are now able to place our second cord to help retract this, displace this gingival tissue in preparation for our impression. It is very important the handling of the soft tissue is gentle and with respect so that we do not cause any potential recession subsequently. And the displacement of this tissue, remember, we don't want to just displace it vertically, but it is more that horizontal distance. The key here, what we would like to do is use one long cord, and you may choose a double zero or a size 0 depending on the gingival biotype and the mobility of the tissue that as you observe. The key is, of course, not to traumatize the area. It is a gentle displacement by folding in and rolling the cord within to the sulcular space. And we really ideally want to just use one long cord and always finishing the tag end at personally, I always leave it in the mesial buccal aspect, so that if there are multiple preps, for example, it's always quite systematic and predictable of where to pick up the tag ends to remove the cord later on. And the real key here is just be patient and wait 5 minutes, because it is this time that the tissue is able to sort of have a little bit of memory in them to be displaced of. And also, I think this time is very critical so that to predictably allow for that displacement. Once we remove the cord, we will have a video later on to show the technique as well, is that we will flow the light body material into this sulcular space. Now, depending on the consistency of the light body PVS material of choice that you have, some tends to have a very high flow and able to just fold themselves into the sulcus. But depending on the position in the arch, you may choose to have a light body material that is less slumping, but which you may have to work with a little bit of air with the property of thixotropy that you can then push the light body into the sulcular space, as what you have seen in this photo here. It has been agitated with the air to try to make it go into the sulcular space more. And then after you do that, you will flow more light body material across the prep as well as the rest of the arch before supporting this light body material with the heavy body in the tray. So here you're going to see a short video of what I had described to you. So once you've waited the 5 minutes with the second cord in place, and as you're about to get ready to do your impression, you will first go around to dry the field, because we don't want to leave any water droplets around, knowing that the material we use is sort of more hydrophobic. So the reason why we want to do this first and not after removal of the cord is because we do not want to disrupt the tissues and cause any bleeding or any moisture through the process of the drying with the triplets. So here you can see how nice and predictable it is when all the tag ends are facing the one direction and the cord just comes out nicely. We leave the second cord in place, and usually that initial 000 cord that you have is only just one circle. And the key of them staying in place is not to have additional length that you try to tuck here and there. You can see here first the light body is being squirted into the sulcus in one motion, keeping the tip into the material so as to avoid introducing any air bubbles or anything like that. And then now, once we have done that, we would use a bit of air action to try and help the material go in to get as much detail around the margin as possible. This is working with that thixotropy concept to try and adapt the light body material even more closely to the subgingival margin. So once we are happy with that, we will introduce more light body steel in more bulk this time. And again, keeping the tip of the material within the material itself to not introduce any voids or air. And as you can see, this material doesn't slump so much, and it's quite ideal when you're working in maxillary region. And here you go, the tray goes in with the heavy body material, and it's important to then use a heavy material with less flow, but it is a bit more rigid to be able to support the light body material that we aim to use for higher detail around the preparation. Okay. So here we try to free the lip because during this motion, we really would just want to seat the tray in one action so there's no ghosting or any images. And we certainly don't want any drag. And you can see how nice the result is, capturing the detail with a good vertical and horizontal circular space beyond our marginal finish. Okay. So this is the end result that we would like to be able to capture using a conventional polyphenol siloxane technique on tooth bone restoration.
Well, thank you so much, Agnes, for covering the one-step impression technique so well. Recently, I've bumped into a colleague during ADX, and he was describing to me how he has pretty much abandoned the need to use a cord, as in the double cord technique. I don't think he's using even the first cord. He's just prep and taking an impression, and he feels that even without a cord, that he could still see that there's an impression tag, or at least the margin of his preparation without any cord at all. And I said to him, "Oh, but you mean you're only doing this for supragingival sort of cases, right? But you still use cord for subgingival cases, right?" And he said, "No, no, even for subgingival." So I was quite surprised when I first heard that, because for me it was just, for any equi or subgingival cases, I just always been taught to use the double cord technique, and I wouldn't have even thought about not using the double cord technique. What would you be your advice or thought about that sort of protocol?
Look, I think every clinician, respectfully, will find tips and tricks and different materials or even ways to go about practicing the dentistry. And I go back to my key concept is that if you can visualize the margin that you want to capture, then it's a matter of material choice and how to then capture it. So what I had described with the double cord is something a bit more predictable and step-by-step wise to be able to achieve a nice impression and a nice outcome. But often I find even when you can visualize your prep subgingivally, often it does not mean that there is that circular width without using a cord placement. And so I tend to think that if, I can only imagine, unless we're talking to the ceramist that the clinician is working with, no doubt he may be able to identify his margin in his impression. But if gone beyond that margin is only a very thin slither of impression material, then the model that gets generated will also only have a very fine marginal gap that they can use to create a die. So it may become really tricky to handle, which is an aspect that the operator as a clinician, you may not always receive that feedback from your laboratory. So that's one aspect. The reason why I use a double cord instead of two cords, again, is to do with a little bit more of the predictability within the clinic. Yes, it does take a little bit more time to place the first cord, and ideally, as I mentioned during the video, the first cord ideally should only do one perimeter around your core. Okay, because the whole idea is that it's already been soaked with the hemostatic agent, and it is placed right at the base, so that as you apply that second cord, this first cord remains down at the base of that pocket, so to say. And the whole idea is that as you remove the second cord that you place that has been displacing the soft tissue, if that first cord will remain, then it's very likely that you're not going to be dealing with a bleeding site. Okay, by all means, yes, there are times where as you remove that first cord, the base cord now gets pulled, right? And in those scenarios, I do not always try to tuck that base cord back in, because if the whole notion is I just want to have that circular space, I don't want to be now dealing with tucking in the cord and jeopardizing all that 5-10 minutes that I've been waiting for. And you do have to assess this scenario, and if that base cord has been pulled, yeah, sometimes, you know what, I just remove it and gently, and hoping that it doesn't cause any bleeding at the base, and I could proceed with my impression taking without that base cord. Yeah. So you do have to use your clinical judgment at times, yeah.
And I'm sure we all have had the situation that when you remove these cords, and especially your second cord, you experience some gingival bleeding, and then that doesn't matter how hydrophilic that your impression material is, at least for the one-step technique, it's still not going to give you a great impression, is it?
So, you know, it depends again, of course, how deeply subgingival we're talking about. For most situations, like, you know, your day-to-day, at least a lot of my colleagues, they do not routinely place a crown margin that subgingivally. So, you know, it has to be assessed case by case, and certainly with a supragingival margin, or you know, if the patient presents already a good sulcular space, then it may not be that you have to, you know, tuck in all these cord all the time. So what I've just shown you is a bit more of an extreme, where you saw how deep that subgingival margin location was, and as such we have adopted this technique, but always critically bear in mind, so wherever marginal placement you are dealing with, however choice you're preparing to embark on your impression taking, the one thing I urge our audiences tonight is, first of all, you must be able to eyeball and visualize what you're trying to capture. And secondly, try to look beyond, not just vertically, but having a bit of that horizontal distance for your ceramist to more predictably be working on the die.
Absolutely. And we'll come to management of haemostasis in just a moment. So thank you for your questions, ladies and gentlemen. Keep them coming, and I'll certainly do my very best to push these questions towards the panel. For impression taking for teeth, to construct crowns and bridges, we all know that there's a number of different materials that are available. Now, Zoe, do you mind share with us what are these different materials? And perhaps when do you prefer to use these materials, as in for what clinical situation do you tend to use them for?
Sure. Okay, so in terms of the clinical materials or impression materials we use in prosthodontics, well, the most common ones. So we have polyether in the form of imprigum. Polyether is an elastic type of impression material. It has the advantage that it's quite accurate. It captures nice surface details, and it can be used for border molding. Now, we've got to remember that polyether is not really compatible with the addition reaction silicone, so it shouldn't be used in combination with that. Polyether is a hydrophilic material, so it flows into the sulcus quite nicely. It captures the details nicely, but it has the property of imbibition. So it does actually absorbs water and swells a little bit as it absorbs water. So as because of that process of swelling, leaving it after capturing the impression with polyether, it's got to be poured within less than 2 hours, because otherwise, with the humidity of the air and the moisture, it actually can lead to dimensional instability afterwards. So the advantage of it is capturing the details, but there's some disadvantage that we've got to be wary of. So if you think about where to use this polyether material, I wouldn't use it on patients who have really a lot of undercuts on their teeth, because with undercuts, polyether is quite rigid. It sets really strongly. It has a very low to moderate tear resistance. So it's actually can get locked in the mouth. It's happened to me before. Especially with special trays, if you ever use it with special tray and a lot of undercuts, and definitely in periodontally compromised teeth where there's some mobility. So you don't want to be breaking teeth off in the mouth or extracting teeth, or actually when you pour off the model into a cast, you can really damage your cast taking that impression. So ideally you cut off the impression tray as well as the like with a scalpel, cut off the impression before you take it off. I wouldn't use it in cases where there's a partial denture construction because of the fact that might be a lot of undercuts and some sort of recession. But for fully edentulous patients, if you want to take a full arch impression, yes. And in implants impression, where you expect some rigidity or you prefer to have some rigidity, then polyether is a good material to use. Now, the next material is a condensation silicone. Condensation silicone it's actually one of the first ever silicone material that was made. It comes in a putty form, so you've got the base and the catalyst, and by mixing those, you got the polymerization reaction happening. Now, the condensation silicone, it has one disadvantage. It releases some byproduct, which is an alcohol-based byproduct. So every material might have some sort of byproduct release. In the cases of the condensation silicone, we've got the alcohol byproduct. So as it polymerizes, the alcohol evaporates into the environment and leading to shrinkage of the material as it sets. It is a hydrophobic material, so it makes making the cast quite difficult, but it does have a high recovery from deformation and high tear strength. Now, condensation silicone is probably, I wouldn't use it as the one material for a crown and bridge impression, but it can be used in a two-step technique. So if you're taking an impression with a condensation silicone, and then you use a wash, impression material, it could be a PVS wash, that way we bypass the alcohol byproduct and minimize the shrinkage of the material, and we get better results. And it needs to be poured also pretty quickly as well. Now, the most common material we use for our crown and bridge impression is a addition reaction silicone. So this is the polyvinyl siloxane. It is the most accurate. There's really no byproduct released. Provide us really good details, good recovery from deformation, dimensionally stable, and it has a really high tear strength. So this material, because it's stable, it can be actually left for up to a month, and it maintains its dimensional stability then. But ideally, you pour it up within 2 days. Now, we've got to watch out with the addition reaction silicone for things that might inhibit the polymerization. For example, you've got the sulfur in latest gloves, rubber dam, hemostatic agents that might have the ferric sulfate or the aluminum sulfate. So these things can inhibit the polymerization. Now, Ben later on will talk about the hydrophilicity and how hydrophobic these materials are. And majority of them, they will have some combination of or varying degrees of hydrophobic and hydrophilicity. So the more hydrophilic the material is, it will flow better into the sulcus and capture the details quite nicely. So we'll cover that later on as well. I think so. And just remember, with this, it comes in different viscosities. So you've got the really light flow material and the extra light, which we use for wash. There's regular viscosity and the really high viscosity material that we use to support our wash impression.
Zoe, you spoke earlier about choosing a hemostatic agent, especially the one that's containing certain sulfur compounds, which would inhibit the setting reaction of these impression materials. So any particular hemostatic agent that you would recommend that would not interfere with that setting reaction?
I think the one we commonly use is it has aluminum chloride, so it doesn't inhibit setting reaction. So that comes in the form of hemodent. You've got viscostat clear, also doesn't have it. I think the normal viscostat has it, has the ferric sulfate, but the viscostat clear is free of it. So this is the one that we commonly use in practice.
Yes. And would you recommend to soak both your first and your second cord in this solution when you're working on patients?
yes, like I normally soak the initial and the second coat as well. And I think with the question, with the clinician that you mentioned,
Yes.
with the first coat,
Yes.
not using a first coat, I think there's an additional advantage to using the coat is actually displaces the gingival tissue by an additional 0.5 millimeter.
Absolutely.
So it helps us protect damage while preparing
Yes.
the margins
Yes.
as well.
I find it from an aesthetic standpoint, it's very invaluable too, because a lot of teeth we work on, it could be endodontally treated where they're already discolored. So you certainly don't want that gingival recession to show up those unsightly margins anytime soon.
Sure.
So by putting the cord, you're placing your margin, your crown margin, just a little bit more intrasulcular.
More sulcal.
So yeah, making more recession proof, so to speak.
Sure.
Now, thank you for covering those materials, Zoe. So Agnes previously spoke about using the one-step technique, and now there's also the two-step technique, another different technique. And Johnson, would you like to cover this two-step technique, what it is about, and how is it different from the one-step technique, and when would you recommend using that?
Yep. So for the two-step technique, you first do a heavy body PVS impression, and then let it set, and then this is followed by the light body impression. The indications for this technique is for multi units. Yep. So this could be 10 units that you're preparing and taking impressions for, or this could be for a patient who is on anticoagulants, and where the medical specialist mentioned that you could not stop the anticoagulants due to the increased risk of heart attack or stroke. So in this case, any bleeding site with one step, it would be almost impossible to take the impression, because as you are doing the impression, the bleeding will be displacing your light body. With the two-step technique, you can either do a putty as a base, or you can do your heavy body as a base. It comes down to your personal preference. My preference is to use a heavy body. It just adapt to the teeth a little bit better. So with your first impression, it just gives you a super close fitting special tray for you to do the light body wash at a later stage. But what are the common problems that can occur? So one, the most common is you unable to relocate correctly. So this can happen to any of the, when we do the putty key for the provisional crowns and bridge. This can happen, and this can happen to the two-step impression as well. So it's very important to remove what we call either the undercuts or the interproximal area of the other teeth that allows you to sit the impression tray properly. You can also mark where the center line is, where the canines are, to give you a bit of a reference. The second problem is delamination. What this means is when you sit the tray, it's very important to have a very constant pressure throughout. Either if you just light pressure throughout, but what you don't want is to compress very heavily, because you try to relocate, and during the process that you let go a little bit, and all that negative pressure, the suction, you will have a bit of a delamination. What is the biggest difference between the one-step and two-step? So one-step is very passive. The ability for the light body to go into the sulcus space is relying on how well you do your retraction with the retraction cord, and how well you get that light body to with some air to go into the sulcus. And then while that is setting, the impression is very, very passive. With the two-step, it's different. The reason the two-step works very well is you have a super fitting closed tray, and rather than putting the light body into the tooth or teeth directly, you put that into the tray or into the heavy body, and you're relying on that compression or the super fit to press your light body into the sulcus. And even if the area is bleeding, or that compression will ensure you take a very good impression. And there's no difference in the accuracy of the between one step and the two step, although some study will show one is better than the other. But if you do that correctly, there is no difference. But however, what you need to be very careful with a two-step impression is you always need to give a little bit of a spacer. The reason for the difference for the one step and two step is for the one step, once you do your heavy and light body impression, when you pull out the impression, the impression does not have a full elastic recovery. So what that means is the die stone is going to be a little bit bigger than the actual tooth. And with that, I mean, some technicians don't even put some of the die spacer in the gingival third, so to have a better fit. So it actually works well in the crown and bridge impression, because all that the larger die will ensure you have a more space for the cement. But however, with a two-step, it's a totally different story. With a two-step, you already have the heavy body PBS that cover the tooth fully. If you don't put any of the spacers in there, the light body, when you put the light body in, all that light body will try to stretch the heavy body, or basically distort the heavy body. And when you remove, you get a rebound of that heavy body. So if we compare the picture on the far right, with that rebound, the die is going to be a lot smaller than the one step. So one is about 80 micron, and the one with a two step is going to be minus 200 micron if you don't give a spacer. What that means is your crown is going to make on a much smaller die, so your crown will not fit. So the conclusion, if you're doing a two-step, you must always have a spacer as a requirement for two-step. One way to do a spacer is to do with your heavy body. You put a glad wrap, and then you put it in the patient's mouth. But you also you jiggle the impression a little bit to create that spacer. And once the heavy body impression is set, you remove the glad wrap. And all this will create the spacer for the light body. And then you finish with the impression. But of course, the more spacer you have, the more you have the potential for the air bubble. And depending on how subgingival your margin is, they will determine how much spacer you give. My preferred way is to actually remove the undercuts on the neighboring teeth, and also give you a bit of a vent. So basically, I can still capture the margin well, and then I also give a bit of a escape, so I'm not compressing or distorting the heavy body as much. So we'll go through a case that I did. So this is a 10 unit, 4.5 to 3.5 that I've done the initial preparation on. So this is done with a gray band diamond only. So the reason I do that is before I do, I want to give a bit of a spacer for the light body PBS. So I haven't smoothed the preparation yet. I'll go and do my heavy body PBS. That is set for 4 to 5 minutes, depending on the material you use. I will then refine the prep, smooth all the margins with a red band or yellow band diamond that will create the spacer for my light body PBS. Even though with a two-step, it is very important to pack your retraction cord. In this case, I go a little bit subgingival to maximize the Faroux effect, and also to hide the margins as well, as some of the teeth are discolored. My first call of preference in this case is 000, and that is my preference for most of my cases. I do my second coat, and then I usually like to wait for at least 5 minutes. In most cases, I mean, by the time I've done this, I'll be about 2 hours into the procedure. I like to give the patient a 15 minutes break, but always make sure, you know, they don't pull the cords out. And then during that 15 minutes, so I'll go in and then I'll modify my first step impression, my PVS impression. So I've removed the undercuts or the interproximal area between the 6 and 7, and I create vent holes on all the teeth. So I like to create vent holes on the teeth. I'm not doing as well. So basically, to reduce the compressive effect on those teeth as well. And then I'll go in and I'll finish with the light body PVS. I mean, even though doing 10 teeth can be done with one step as well, but sometimes you capture 8 or 9 teeth and then you have to redo just for one tooth. So I do find 2-step impression just a little bit more predictable.
Right. Thank you, Johnson. How did you go about picking your second cord? Is there a rule? Is there any hints, any advice that you'll give us?
Yeah, usually I do find that depending on the sulcus space, so basically going with a perio probe to see how far you can probe and then how easy is it to probe. But I do find 00 is a little bit thin. I just don't get enough sulcus space. So I do find a minimum for the technician to see will be more of a 0. But unless it's very thin biotype, then I go for a little bit smaller cord. But all depending, once you stretch it, if I find even with a 0, I still find the gum is still covering, then I go for the next size up. So after the second cord, I don't want to see any gum covering the tooth.
Of course.
Yep.
Of course. That's why having a slightly longer strand, so you can potentially go round and round a few steps is also quite helpful, isn't it?
Yes.
One of the audience asked that, do you need any adhesive between your base impression and your wash impression?
No. You don't need any adhesive between the
But you do
the
want
base
to
and
ensure the surface of the heavy body impression that you had taken to be nice and clean and dry.
Absolutely.
So that is why, Johnson's actually demonstrated different technique of capturing that the heavy body impression first. And one of the technique, the reason why you see the glide wrap being there as you place and jiggle and move it a little bit, and that glide wrap is serving to ensure that pristine and dry surface to then go on to the light body wash. If you had done any modification, trimming, or picked up a burr to make the vent holes, etc., you may find that there are going to be dust and residue, which it is okay to wash that surface with a little bit of mild soapy water, because soap can get rid of the water moisture. But then you just got to dry it really well, so that surface now should be able to adhere with the light body well enough. Both the pressure in, the maneuver of putting too much pressure during the light body capturing, as well as having the surface being contaminated, both situations can create this delamination or lack of adhesion between the two PVS material. But I think Johnson had given a really nice description of all the step by step and all the clinical choices one can have in their armamentarium. But I think it brings back home the point of you have to know what you're trying to capture, and just having that understanding of the technique behind which philosophy to adopt to suit your different clinical scenarios. So that was very nice, Johnson.
Absolutely. And how do you go about choosing the instrument to use when you prepare your vent hole? Is there a particular burr size or any particular instruments that you use to do that?
So the vent holes in here, because I've created spacer by using a smoother burr, so I just use a straight like a number 8 rumble in a straight handpiece, because if you go by the normal slow speed, it's just not long enough. Yeah.
Slow speed, is that acrylic burr slow speed, or
no,
like a caries removal
caries
burr?
removal burr is a little bit a little bit too short.
Too
unless
short.
you get the long one.
Yes. Yeah, for molar size, usually I just like to use the acrylic burr in a lab handpiece, especially that's quite big.
Yes.
And you want as much venting as possible from that occlusal surface. It's not going to affect your marginal accuracy one bit.
That's right.
But certainly for lower anteriors where they're so small. No lab burr is going to do that for us. One of the participants also asked, can you do a mix and match of different brands of materials between your base impression and your wash impression?
Oh, I mean, when you do one step, I mean, the recommendation is always going to, you go follow the same manufacturer. So basically, same chemistry. With the two step, I mean, is less well defined. But basically, I go by the same principle. If you use the same brand for the heavy body, you should go for the same brand. So I think in theory we should stick with one brand just to avoid the potential issue. So maybe it's a setting issue, or maybe it's the binding issue between chemistry, the PDs, just in case. But I guess in theory it doesn't stop you from the compression doesn't stop you forcing the material down. And I do know quite a few clinicians actually do that, whether it's using the one-step concept or the two-step concept. They like to use, say, something like putty, which gives you even more rigidity. That's right.
And then load it with light body, or at the same time trying to using one step, which is completely two different products.
That's right.
One condensation silicone, one additional silicone, even then, and different brands, and they combine those together to try to capture those impressions. I guess I know many people do that.
That's right.
But according to the manufacturers, it's probably not a good idea. All right. Quite a few questions, and I think that this is where the majority of the questions will be coming from. It is during teeth taking impressions. So we're just going to spend a couple more minutes on this. What instruments do you use to pack the cords? Do you use a flat plastic? Do you use an proximal cover? Do you use a cord packer? Any particular recommendations?
I am comfortable to place my cord with either a flat plastic or a cord packer that is not serrated. Personally, I find that it is a bit more kind and not tend to tear or fray the cord so much. And because I think technique-wise, I tend to roll or fold and then tuck in the cord, and I never really use any vertical pressure per se. So those would be my preferred instruments.
You guys?
Pretty much the same. I do use serrated for posterior teeth.
You like serrated better?
And I actually sometimes even like to use a amalgam cover.
Yes.
It's it does the point. It's just small, no vertical pressure. You just gently roll that cord in. It just has a nice point where you can control that cord into the sulcus.
Yeah. I know you said earlier, Agnes, that during your presentation of when you remove before you remove the second cord, you actually dry it first. And that concept is to ensure that the soft tissue is also as dry as possible, so that when you introduce the light body to that gingival sulcus, it's not going to give you, basically it's going to give you a better impression. One of the question participant asked that, would you consider wetting the second cord? So basically it's the opposite, because so that it doesn't tear or attach to the gum. Or that it dries and sticks to the first cord.
I think this is where the clinical handling is a little bit different. I tend to only dry the field, of my preparation. I don't really deliberately go and dry the cord per se. And when you are placing this correctly, usually the sulcus have a lot of crevicular fluids, and I very rarely find that my second cord is so dry that it tears on that tissue.
Yes.
I do find that that could be a potential case at that base cord, and that's why personally I like to be able to keep the base cord.
Yeah.
It is sometimes that when you remove your PVS material, that base cord may come out with it, and it may not. And if it doesn't, and even if you gently remove that base cord, it is common to see at least a little bit of bleeding
Yes.
or whatnot. So no, the top cord that you use to displace tissue, if you've wet it with a hemostatic agent, so there's already some wetness in the cord, and plus the fact that there is that crevicular fluid that you expect to seep in that space. I haven't really come across a situation where it is so dry that I have that concern. Yeah, and then I don't really dry that second cord too much either. But so long as when you look down in your prep, you can visualize with clarity the area that you're trying to capture. And by that, of course, I don't mean to see any more exudates from this area, because assuming a lot of the time, even though we have to work subgingivally, ideally the site that we've chosen to do these reconstructions on are of reasonable health. So we should not be really expecting a lot of exudate per se. So I think those are the parameters that we work with.
Especially, I think quite often with our second cord, we actually go round and round the tooth a couple of times, sometimes even 3 times. So what you're drying is essentially just the top layer of that second cord. Your second or perhaps your third layer is still actually reasonably moist.
Yeah.
So very rarely do I find when I take out the second cord, the first cord comes with it. That's very, very, very rare.
The first cord comes with it only if, as I have observed, sometimes when we do demonstration or teaching as well, commonly if the first cord placement is not just the exact circumferential, sometimes the cord is a little bit longer, and if we're a little bit reluctant or lazy or whatever it is the reason, we didn't choose to cut it and tuck it neatly, we just choose to extend. Then I think it is that extra bit that sometimes might come off with when you remove that cord. And then, but it's not the end of the world. If it happens and you've got a nice stable site, then by all means just remove it rather than tuck it back in and
For sure. There's another question for you, Johnson, and this member of the audience had a very cunning thought. So this situation is you've taken a one-step impression.
Yep.
And you notice, oh, bummer, I've got a little bubble there.
Yep.
Can you use this as a two-step technique? So now you, I guess, put in a little bit more light body. And then push this back. So you turn a one-step impression now using a two-step concept, and to repair, so to speak, that first impression. What would you think of that?
I usually just go in and restart the whole process.
And why?
Yeah, because I just because there's no research to say you can. Unless you remove all the light body, which you couldn't, but there's no research to say light body will adhere to light body again. But in theory, it should.
I think it's not just the adhering; it's creating another layer.
That's right.
So you'll never get the impression to see it fully.
Very, very
and
difficult.
And you will have an additional layer sitting on top of your existing layer. That's going to be not accurate at all. So unlikely that you're going to go all the way through the interproximal areas where you've taken the first impression without really going with a scalpel and cutting all those areas and venting like Johnson had mentioned. And then you can use another layer to seal on the gap, but then it's an additional work. You probably easier just to chuck it and start again.
It is.
I wouldn't really just chuck it. if the first
I can repair that.
But having said that, I agree with all my lovely colleagues here. But in theory, I agree with Zoe. Like by the time you go around and trimming all the interproximal, because for this particular audience, you can't just reline just that one tooth. because there is potential that you may not be able to receive such a highly accurate impression like a tray. So there would be discrepancy for that one unit across the arch. And secondly, then by the time you have to trim all the interproximal and take away all the high detail basically, and vent the hole over your prep, you may as well just do another impression, but this time, hey, just do it two-step to be a little bit more predictable, to control the bubble and whatnot. But you know, if your first impression that you had taken already, it is available, and there's maybe just one bubble in a critical area, but it still capture all the other detail, by all means just send it to the lab and just have it as another die to, like, you know, compare against, knowing that the second like the two-step technique, sometimes there is that variance of the die being a little bit smaller, and using the die spacer, etc. So you know, the laboratory often they will have a working model, and separately they have to make a die anyway. So there's certainly some merit if it's worthy enough to not just chuck it and just send it to the lab as a second record.
I do understand from time point of view. It's like often you do the impression and then you still have the temporary to go, right?
And
so
your patient is already, your next one is already waiting in the waiting room.
So
you're running out of time.
So first step is 5 minutes, modification another 5 minutes, and then setting another 5 minutes.
5 minutes.
There goes 15 minutes.
Yeah.
So I do think
and there goes my lunch break.
and dental assistants are not happy. Right?
That's right. No one's happy.
So I do understand, you know, my go-to is, you know, depending on if some patient will say they have stopped the anticoagulants, but some patients, after you pick the second course, still bleeding. Then you basically, you know, the likelihood of you doing a one step is
pretty
going down. Yeah.
So what on that topic of hemostasis, there's questions on what are your tips on reducing that rate or that risk of hemostasis?
Well, one is pre-op any natural blood thinners, vitamin E, garlic oil should be stopped, or
fish oil. That's a big one
for sure. Operative, I mean, retraction cord injection containing adrenaline will usually stop, and some people use the electrosurge laser to stop as well. But usually, me just using retraction cord and then LA usually.
Into the papilla. Yeah, that's it. No, thanks guys. So of course now we've gone over the techniques quite a fair bit. Now I just want to cover the material or the properties of impression material a little bit. Hydrophilicity or hydrophobicity, of course, is a concept we've all been taught in the undergrad level, which is how much a water will like or dislike water. Now, this particular measurement, or how do we measure hydrophilicity, is typically at a laboratory level, a little droplet of water is being depressed onto the material that you try to measure. And then after a period of time, that water droplet slumps down onto the material. So here on the left side of the screen, you're seeing a drop of water on a light body PVS material because it's fairly hydrophilic. So therefore, and then they measure the contact angle of this water droplet to the PVS. And if it's an acute angle, being less than 90 degrees, then this material is coined hydrophilic. And if it's the other way around, where the water hasn't really slumped very much and the contact angle is greater than 90 degrees, and that's called a hydrophobic material. So that's a concept that's quite easy to understand. Now I'll skip across to this particular video. Now a little background on this video. This video was shared to me by Dr. Felix Worley. Now he's not a dentist, he's a material scientist, he's a chemical engineer. He's the head of science for DMG in Germany. So when I visited DMG quite some years ago, this is the video that he shared with me. So I want to share with everyone what I also witnessed and to learn a little bit more about it. So in this video, what you're going to see is that Felix has he's using a two-step technique. So he's already done a base impression using heavy body PVS. And now he's going to take his impression at this full arch impression while underwater. And what he's trying to I guess showcase is to say, well, in the most wet environment, this is just being almost a little bit silly. The mouth is never this wet, but in the most wet environment, how do you go about, or how could you obtain a very accurate impression, and therefore what can we learn out of that process? Felix already taken his secondary impression, and then with the light body, you can see him injecting the light body underwater around the teeth. And of course, that's just going everywhere. It doesn't matter how hydrophilic your material is when there's say gingival clavicular fluid or blood around your sulcus that you try to capture. It doesn't matter how hydrophilic it is, right? That material is not going to capture the teeth accurately. And then he injected the light body into his base impression, as you would with a two-step technique. And then he's taken that impression, he plonk that underwater after a period of setting. When you take it out, and ta-da, it's basically a perfect impression. And when I first saw that video, I was completely blown away, because I'm like, well, my question for him straight away was, wow, how hydrophilic is that material? And B, just take my money and where can I buy some? And what he said to me was that, well, I'm sorry, Ben, but those were very horrible. Those are bad questions to ask. What you should be asking is the why. Why is it, as a non-dentist who's never taken an impression in the patient's mouth, how I'm able to take a full mouth impression while underwater, and it's perfect. It's bubble. There's no bubbles. There's no defects. No nothing. So it was during that period of time when he shared with me the concept of thixotropy. Now, here on screen that we can see that there's two different materials, one on the left, one on the right. The one on the left, we can see that kind of slumps a little bit onto the surface. That's a fairly low viscosity material. That's coating Weldent affinis. I used to like that material a lot because it's very runny, in other words. So it's very hydrophilic, low contact angle, so that when you inject that very low viscous material into the gingival sulcus, this material basically just kind of slumps by itself.
It's like, I guess in areas you call it slump.
Yeah.
But in good areas where it's not slumping and going down the patient's throat, it's so attractive to see. It almost wants to run itself away into the margin and do the work for you.
That's exactly right.
That's the good one.
That's exactly right.
Yeah, but also it can run itself down the throat.
It certainly can. So what you can see on screen here is that's the material on top, so that when you apply a little bit air to it, you can really see it's beautifully thinning out perfectly, and it's well adapted to the margins. Whereas the material below, this is honeycomb from DMG, which is quite a more viscous material, but it has the properties of called thixotropy, which by definition means the ability for a material to flow while under shear force. So that means when you blow air to it, or when the material flows over the ledge, that's when under shear force, right? That's when the material breaks. So you can see that this material can also be thinned out very nicely. But however, where you don't blow air onto it, those little tags, it stays at where it is. So in other words, it does not slump when there's no pressure. So like what Agnes was saying earlier, that if for a very low viscous material, there's some drag sometimes, at the distal of the 7 or something like that, when the patient's lying fully supine, I sometimes get drags in those areas. Now I have to repeat my impression, not because I couldn't capture the sulcus or the margin, but because of these drags. Whereas with these thicker, more viscous material, but with the properties of thixotropy, we need to blow a lot of air, so that the material is now you're getting your money worth. Now this material is working for you, and it's getting into the sulcus. So let me show you this particular case. This is where this is a fairly deep subgingival margin case, and I did a horrible job at controlling haemostasis. I wasn't able to do that fully. So but still, I was too late. I was already injecting light body into it, and I saw then blood was pouring out of that sulcus, and I knew that it was not going to be a good impression. Nevertheless, I tried my best. This is what it looks like. This is a one-step impression, and you can see that the margins are not clinically acceptable at all. There's little bubbles, there's little voids, and you just cannot read that sulcus width and that depth that Agnes was speaking earlier. Now, I did not want to stop there and then, so now I'm going to use a two-step impression technique because my next patient was not waiting for me. I still had a little bit of time left. So using Johnson's technique, base impression, then a wash, which is the impression on the right, and here you can see that on the same day, on the same patient, using exactly the same material, but using a different technique, I'm now able to depress that bleeding from that gingival sulcus and get a much more acceptable impression, as in now tying together the materials and the techniques. Sometimes we got to do some cases that has so many more number of units, sometimes even full arch. As I was saying earlier, Zoe, any particular tips for our audience tonight on how to potentially carry out an impression for multiple units or even the full mouth?
Sure. Okay, so sometimes we have to take a full arch impression, and when that happens is aiming to give the patient, say, upper and lower, maybe 12 crowns or even maybe more. The things that we can help us, so any things that we've spoken about earlier on in terms of using that distal drag that you on the 1/7 that you saw with Ben impression later on, earlier on, we can use intra-oral syringes that will can get into nice tight places and flow on the palatal aspects of the upper molars. Also cotton rolls, and we talked about materials, maybe that you can have an extra light flow material as a wash as opposed to just a light flow that will help just to flow that little bit extra into the impression sulcus. So this case that I'd like to share with you, it's a lovely young man. He had amelogenesis imperfecta, and he was treated initially in pediatrics with a number of provisional crowns, that art glass crowns and stainless steel crowns that served him quite nicely for a number of years. But he came to the stage where he's now above 18, and he wanted to improve the appearance of those teeth, and you can see there's some of the crowns has come off. He had some extra recession developing on some of his teeth, that's showing that yellow root surfaces, and he's a guy who's got really a thin gingival biotype, and he's probably be at risk of even developing a bit more further recession. So as you do with any of those big cases, you've got to look into radiographically here. You can see on the x-ray if you can see it clearly, but there's a lot of issues underneath his existing crowns in terms of secondary caries, some of marginal defect or overhanging margins with the crowns. So we decided to redo his construction, and again, when you do that, you've got to start with removal of the crown and assessment of the teeth, tooth structure, individual teeth, make sure that they have good long-term prognosis, there's no secondary caries underneath them, restore them, and you start with a diagnostic wax-up, which we base on your provisional crowns. To get the incisal edge position, just treat it as any normal case. Now with this patient, because of two things, first of all, he's got a very thin gingival biotype. There's an X amount of teeth that was really difficult to capture. The decision has made to minimize any trauma to the gingival tissue and also avoid inducing further recession. Plus, the difficulty of capturing all of those teeth in the one impression. The decision was made to take alternate tooth impressions. So initially we did an impression of the 1-3, 1-1, 2-2, and then so just alternate teeth. So you capture those teeth in the one impression, you bring them back, you capture the other number of teeth that wasn't captured correctly in the other impression. And now based on those, we have generated what's called like a die. So these are individual dies that they look like that. So you've got your dies, and based on those dies of every single tooth that you've captured correctly, now we can make what's called bonnets. So these bonnets are made on either Duralay material that's made on the die in the lab. And you can see there's a little of vent or spacer or venting holes here. So these are to ensure that when it's seating on the die, it's seating fully and it captures circumferentially a good thickness of the die. And then you seat it in the mouth, and it has to have exactly that tooth surface showing through. So you know for sure that all those bonnets have seated accurately. And then using a very rigid impression material, for example, polyether. So it captures and encircle the rough spots on these bonnets. So you don't want them to make them nice and smooth that they slip away. You want to make some bumps, some blobs on them that they actually get encapsulated within your polyether impression. And then as you capture all of those, we put the dies individually inside the impression. It's a lot more work, labor intensive, especially later on pouring the models so the dies don't actually move and they sit inside that impression without any discrepancy. And then finally, we got our final model. So you've got the upper and lower models. Now, with these models, now we have to make sure that they actually fit on the model as they actually do in the mouth. So what I did is made like impression compound on a face ball. So there's two purposes of that. Is first, that compound will help me verify that the way it's sitting on the teeth or the die on the model, using like a bit of Tem bond to verify the incisal edge position on those, is actually the same way it fits in the mouth. And then we use that to mount the models later on an articulator and also to record the bite. So then from that, the lab can actually make us the crowns, and hopefully those crowns, based on all the steps that we followed, those crowns should fit exactly as they are in the lab, as they do in the mouth. Now, doing a full arch impression in that particular way is a lot harder than carrying it in terms of doing a one-step or even a two-step technique that Dr. Chou has showed you. But in this case, it was necessary because we couldn't capture all of those teeth in the one slot and the one time, and we didn't want to induce any further trauma to the soft tissue. So this is one way, and I'll share with you. So that's the final results, and it fitted exactly with the occlusion and everything that we were hoping for.
And I think just to reiterate what Zoe was mentioning, to look after the soft tissue. The reason why she does the alternative during the process is because the potential of placing the gingival retraction cord on adjacent preps in thin biotype and in such a deep prepared case scenario is not to damage the coal. So what the coal is that interdental papilla by this, like sort of just strangling it with the placement of the cord.
Especially when you have so many teeth.
That's right. And so that is the reason why she was referring to only being able to capture alternate tooth in that process for those.
Okay. Thank you, Agnes.
No, that's a beautiful result, Zoe.
Thank you.
One question asked is on pastes, retraction pastes. What do you feel about gingival retraction pastes? Are they adequate to provide you with those sulcus width and height? Do you use them? What are your thoughts?
I actually saw them at ADEX, from Voco, I think, and
yes. Expasil was one of the first ones that had it before.
Expasil there was. So Expasil I've used before, and it does work quite nicely. There's also retraction. They come like a circular shape from Voco, and you just pat them in place. Yes. So anything that will give us the vertical space as well as the horizontal space, I think that should be sufficient.
Yeah.
In my hand, I prefer the two chord technique still, bit old school, but
yes.
But if you're comfortable using the Expasil, absolutely.
Yeah, I find gingival retraction paste is great for haemostasis, terrific, and obviously it does make the tissue shrink somewhat. But I feel that does not give me enough that circular width that I'm looking for. So depends on, I guess, how deep and subgingival these cases are. If it's quite deep, if it's quite subgingival, I still prefer to cord technique myself, because I can see where that the sulcus space is when I'm injecting in that light body, as opposed to any other sort of type of techniques. It's just not enough material getting down there.
Yeah, I think in the end it goes back to if you can visualize what you're trying to capture.
Yes, that's it.
Then, yeah.
All right, thank you for tuning in, ladies and gentlemen. Once again, if you would like to receive your CPD certificate, please do not forget to scroll down to the bottom and key in your name and email address. We're just going to take a quick 1.5 minute break, intermission break, and we'll be right back. And welcome back. Hopefully you've refilled your popcorn cups and your teapots. Thank you for joining us again. Just a reminder for everyone that's interested in the Noble Biocare Mentorship Program, go and Google that information and hop onto the website for anyone that's interested in furthering your dental implant education journey. And also for the ones, just another reminder that for the ones that's wishing to win a Hayes chocolate hamper package, check your emails for that QR code and scan that code in, fill in the form that's regarding experience services to potentially be in the draw for our Hayes hamper package. So now that we have covered impressions for teeth, we're going to take a slight different direction, and we're going to cover a little bit on dental implants, because I know that quite a number of our audience are doing implant prosthesis and taking impressions on dental implants. So just a little bit of tips and tricks and here and there of how about doing that and the why behind it. So for the ones that's aware already, there are two different techniques. There's the open tray and there's the closed tray. And the open tray meaning that you literally cut a hole in the tray, and hence open tray. There are many different types of impression copings that are available, obviously depending on the implant manufacturer, but most of the reputable implant manufacturers, they will give you a number of different types of impression coping, even for the same platform or the same diameter implant. It could be varies in diameter or varies in height. So how do you go about deciding what is to use for what? Well, the impression coping ideally should be corresponding to your healing abutment. And take this case, for example, the healing abutment is 3.6 millimeters in diameter. That's it right there. And so therefore your impression coping also should be 3.6 millimeters in diameter, because any wider, if you were to use, say, a wider impression coping like this one here, which is 5 millimeters wide, although it's same for the same platform, that will simply not fit onto this particular case, because you can see there's still crestal bone right beside that healing abutment. So diameter is important, and therefore if you do refer cases out to a surgeon to place your implant for you, in that surgical report they must have the diameter of the healing abutment. Very, very important. Next is, of course, is the length or the height. For a lot of the anterior cases, personally I prefer to use a longer version, just so that when you take an impression, it's much easier for the impression guide pin to poke out of the impression, as opposed to you're going to dig forever to find where it is. As opposed to the shorter one, obviously that's more for posterior cases. Once your impression, once your healing abutment is off and you're ready to take an impression, I always recommend to use a little bit of topical anesthesia, and you just rub that into that little well or that little cup of your soft tissue, and that just significantly improves the comfort for your patient. And once the impression is coping, that you feel that it is all the way on, one of the most important part is to take a perpendicular PA. And what you're looking for is the sharpness of the threads of the implants on both the mesial distal sides. And if you don't see the sharpness of the implant thread, that means your PA is at an angle of some sort, and therefore that PA is not diagnostic. And to help you to achieve the most perpendicular radiographs, then you should use a PA holder of some sort. And if you're not exactly too sure what to look for, then you can always request one of these types of PAs from the implant manufacturer, where they will tell you what should it look like when things are properly seated. And just to drive this concept home, why this is so important, so let me share with you this particular story or this particular case. So this patient was referred to us because the patient's implant crown came loose, and the referring dentist had a difficulty at seating the crown back down. So he could feel that he could tighten things, but then when he would take a bite wing or a PA, he could notice that, hang on, the crown is not fully seated into the implant. What is going on? Why is it this crown has been working in the mouth for 6 years? All of a sudden, the abutment screw came loose, and now I can't get the crown to fit properly. So he also supplied us with the PA that was taken on the day of crown insertion, which was about 6 years ago. On that PA, it appears that the crown is fully seated into the implant, and that's what puzzled him even further. As in previously, he has some sort of radiographic record to show that things are fitting properly, but now it is not. Now, when we saw the patient, this is what we saw. You can see that the top part of the image is that's the triangular shape of the internal geometry of the implant, and that triangle is facing, the tip of the triangle is facing mid-buccal. And that means the abutment, in theory, which is the picture below, that triangle should also be facing mid-buccal, but it is not. That triangular abutment is facing towards, I think it's the mesial buccal cusp or something rather. So straight away, we realized that the abutment is not actually aligned at all to where the implant is. So therefore, what this story has taught us is that this PA, as you can see, you cannot see the sharp thread of the implant. So therefore, this is not a diagnostic PA for implant purposes. And this dentist, he's also did not take an impression, a PA during the impression stage. And that means most likely when he put on the impression coping, that actually was never seated into the implant, but he never knew about that. He's taken the impression, and then so the master cast was made, and then which was incorrect, and then the crown was made on the incorrect master cast, and then he fit that crown miraculously into the mouth, which was again never seated properly. But then when he tightened the abutment screw, miraculously that abutment screw never came loose for 6 years. And also it's miraculously that there was no crestal bone loss despite the marginal misfit between the crown abutment to the implant. So that's why, you know, taking the PA per se is not what you're looking for, but it needs to be the X-ray beam needs to be perpendicular to the implant so that you can see the sharp threads to make it into diagnostic. So, you know, these are all my PAs. So if you take a PA looking like what I did, where both sides of the thread is not sharp, well, these are not diagnostic PAs. You just have to apologize to the patient and do it again. There were some other questions on I received before our presentation on the topic of, well, how do you take impressions when there are multiple implants? As an implant, if you do the implant bridge, how do you about doing that? So this patient, as you can see, is missing a couple of teeth on the front, and there are two implants, and we want to construct an implant bridge for this patient. So once again, once the impression copings are on, we need to take a diagnostic PA to confirm that. Now, our method to take a multi-unit implant impression is to splint them rigidly. There are many different ways of splinting. This is personally, this is my favorite technique, is to use a rigid wire, and these are about 3 millimeter thick stainless steel wires, which means you're using your fingers, you can't really bend it, and we cut it to length, and then we lute that using light cured resin of some sort. This particular product is it's called Triad Gel. It's from Dentsply, which unfortunately is no longer commercially available. So now you can use something like a flowable composite resin. That's one option, or you could even consider using a gingival barrier for teeth whitening. But those materials are a little bit softer in thin sections, so therefore you need a lot more bulk of that material to help to lute your wire to the impression coping. Now notice that the resin is not touching each other. So for example, in this case, they are quite wide apart, but there are some cases where the implant could be next door to each other. So in those cases in particular, you don't want the resin blobs to be touching each other, because with all resin, there's some degree of polymerization shrinkage, and when things shrinks, you don't want them to shrink towards each other, which will pull your impression copings towards each other, right? You just want it to slump and to pull towards the central part of the impression coping to rigidly splint the impression copings and keep things as accurate as possible. And then again, using open tray technique, construct the prosthesis in one go and then issue it. For full arch impressions, we use exactly the same technique. Rigid wires, one on the buccal, one on the palatal. So here you can see that this is a gingival barrier, a resin of some sort, in much bigger blobs, again, to maximize its rigidity. Open tray impression technique. And so when you now put on your dummy implants or your implant replica, you'll find that everything is rock solid. So this gives me 100% confidence that the master cast is going to be accurate, and therefore the prosthesis, as long as it fits the master cast perfectly, it will fit the mouth perfectly. As we're running a little bit over time, I won't go into detail about closed tray impression coping, closed tray technique. It's in brief, it is when the patient has a limited opening of some sort, or perhaps you're working at the site, say the 7 especially, and the patient just can't open very wide. You do have to use the closed tray impression coping to do these procedures. They are quite small, sometimes even difficult to fit on intra-orally, so therefore taking a good diagnostic PA is even more important to make sure that they are seated down properly. And the reason why this is not my preferred go-to technique, but instead my secondary or last resort, put it that way, is because you have to literally rip this impression out and then take out the closed tray impression copings, connect on your dummy implant, and then you push it back into the impression. So therefore, there is some variation of potentially distorting the impression material during that process. So sometimes the rigidity or the degree for you to move your impression copings within the impression is larger when compared to the open tray, which has more undercuts and anti-rotational devices. So that's why this particular technique is it's not our go-to technique, but it's only when you don't have much of a choice. Now, when you have teeth and implants all together in one arch, here is where we can start to combine everything that we've been talking about today. Here you can see we have teeth, we got single unit implants, we got multi-unit implant prosthesis. For teeth, double chord technique to give us that sulcus expansion, depth and width that Agnes spoken about. We are going to splint the impression copings for implants to maximize the rigidity and the accuracy of our implant restorations, and also going to use an open tray technique. So that in one impression, we can capture both accuracy and maximize the rigidity. Then we have the confidence for our lab technician to make all the prostheses in one go and to issue all the prostheses in one go. Now we're going to take a slight, again, deviation towards impression taking for tissues, because for full dentures, you're talking about primary and secondary impressions for full dentures. Many dentists may feel that, well, we're not doing so much dentures anymore. We're only doing implants these days. Why is this still valid? Well, I still think it is, because even for full arch or full mouth implant dentistry, I think the ability to make good dentures to begin with, to work the patient up, is still very, very important. So Agnes, could you share with us, how do you go about taking impressions for dentures?
Oh, excellent, Ben. Thank you. So to change the dynamics a little bit, we've spoken about taking record for high detail or for rigidity, and basically we have been capturing details that are passive. So on the flip side now, as we move on to talking about doing full arch edentulous impression, we have to think about dealing with tissue space. And the types of impression that we are about to take for the fabrication of the prosthesis is no longer passive. It's going to be dynamic. There might be functional molding. We got to examine what we need to visualize here is commonly a lot of the times people would look at my ridge form. Do I have a good height of the ridge? Many people, for example, in the edentulous mandible would look at frenal attachment. We would look at whether we have stable or mobile or deformed retromolar pads. But one thing that I really encourage clinicians to actually examine is to look at the sponginess of the soft tissue. Where are the compressible tissue? Now, many of us will know a go-to in the maxilla to look at around the poststem, because that is where we would have to carve in our cars to create the poststem, to create the seal. But equally, it is important in the mandible to have a look at the quality of the soft tissues. And also around the borders is where we would consider where are the compressible tissue. But along the ridge, the quality of the examination includes the friability of the tissue. So are they quite thin, easy to have denture sores, or are they quite mobile and flabby? So these are important to examine. These are the things now we want to visualize. And if you're able to examine and visualize that, then you can decide on how to capture it. Like Zoe had mentioned, a lot of the different impression materials, and on top of that, we now have also green stick, compound, and zinc oxide udinol. To me, these are the different materials that one can consider, but highly dependent on your relationship with the laboratory that you work with, the practice that you are in, what stock they have available. Today, I would think that a lot of the times with alginate or even PVS with the different viscosity, we would be able to use our material knowledge as well as the clinical practice to be able to use different materials to capture the same result. So the main thing is looking at the properties of the handling when we want a bit more viscous material to be able to have the compressive effect, when we want to have a bit more high flowing material, and whether we choose the technique to compress or whether we inject the tissue, the material onto the soft tissue to be able to be more passive. So it's more related to technique. And then the choice of material will be highly dependent on whether are you pouring your own models that you're able to then deliver to the lab, or do you have the lab support to come and handle your impression rather quickly in terms of your decision of what materials to use. So here you can see what I'm going to go through is a case of how we are able to capture the primary and secondary and subsequent impression taking of an edentulous mandible. So commonly your patient may come in with existing denture, and in this particular denture base you can see that it's been realigned at different times. You can see that there are areas where there are good anatomy of the border extension or the capturing of the retromolar area, but it looks maybe a little bit overextended. But if the patient does come in with an existing prosthesis that, even though there may be qualities that they dislike, oftentimes you can duplicate that denture to become a secondary tray almost instantaneously, that you can also have the teeth in position where it can be altered if you want to change OVD, but at least it sets a platform for you to capture your OVD and things at the same time. But a lot of the times we don't have that luxury. So we do have to start with a primary impression. So in this particular case, Dr. Lee has, this is a case by Dr. Ben Lee. He has utilized alginate to take, in a primary model, we want an overextended impression. So typically you would mix this alginate with a little bit more body. You don't want it to be too flowing. And you can notice that you may even use a standard stock tray. And that is why you do deliberately see that there's a lot of overextension to that sulcular width. However, we are able to still see the frenal band. So rather than a thin frenum, you actually see a whole muscle band because it's been pulled. And also, like you can more or less see the floor of mouth movement demarcating that floor of mouth line. It is nonetheless a very overextended impression, but it captures all the border that we do want in our final. And what it looks like on the model is you do see those very wide closure space, or the sulcus space. And in an experienced eye, you would be able to now come here and critique that within that sulcular space, you can still see where the frenal attachment would be. And this is what I'm talking about. Instead of just seeing a frenal pool, you do see a whole band of muscle along here. Okay, so when you are going about to make your secondary tray, while you may have the experienced eye to now have a look at where to shorten the tray to allow for the border molding or the movement to occur, if you are not confident with that experience still, you would be able to at least do some disclosing of your tray so that you can then critique it and do the trimming. Okay, so here you can also then bring the tray into the mouth to exactly approximate and to actually see whether it allows for the muscle movement. This is not the only technique that is available. It is just one of the techniques because it highlights the fact that when we are dealing with a different material, the balancing aspect is the amount of space that you're working with, balancing with the type of flow of the material. So in this particular technique, there is no stops in the tray. It is a very close fitting and approximation of the tray, but with the tray extension to allow enough room to border mold. Okay, so here you can see that the adhesive had been applied. And because if you recall the photograph of the original ridge, even though there are uneven topography in the interior aspect of the ridge, the tissue quality is quite uniform and robust. So we are not too concerned about the molding in this area, but there was a lot of dipping in the posterior mandibular area. And in particular, we do want to ensure that we go into the submandibular concavity and be able to capture nicely the retromolar area. So in this particular instance, the border molding is only contoured in the posterior mandible. So here, what the material of choice here is chosen is green stick. With the green stick, it's very important that I find you handle the green stick with a water bath. Yes, I do see many spinning the green stick over the Bunsen, but when you hit the green stick in that way, it just never uniformly softens the wax. And that uniform softening of the wax is a very important property when using this material intra-orally to do this molding effect. Doesn't only just create a sense of comfort within the patient's mouth, and that is very important as you try to get the patient, especially dealing with full denture, to have this functional movement, but it also becomes more pliable before it reaches its set. So after the initial green stick and the border molding in this area, adhesive for PVS is the material of choice in this case, was then placed. And a regular setting PVS is being utilized uniformly across the impression. So as I mentioned before, depending on the case, you do choose the different viscosity to achieve the different effect. In this case, because we've already done the border molding and we're quite happy with the extension of our tray, then that is why only a uniformly across the arch, a regular set PVS is now used. The reason we only use a regular set and not any fast setting PVS is because we do still require the time to do some border molding. It is not completely setting like a passive impression. You will also notice that the handle of the trays are very important. Where possible, I do like to mimic a closed tray technique, which means ideally, if assuming we had the original patient's model to duplicate to become secondary tray where they can actually close on it and do all the movement, it would be ideal. But when we are actually using a customized tray, it is very important that the handle of the lower tray is more or less like a 90-degree so that it just sits comfortably over the lip. And once you've inserted this tray, you can then get the patient to slowly close to where a comfortable lip resting posture is, and then to do those slight movement and to posture the tongue a little bit more forward, and that the handle is not in the way. Equally, in the upper arch, the tray, the handle design should have like a 45-degree, allowing that handle to just rest gently with the lip being at a more or less a rest position rather than bulging out. So all these are in consideration with the functional aspect of the impression taking. So when it comes to the material, it's really a balance between your understanding of the material, the tray spacing, and so forth. So here then we have a secondary impression that captures all the aspects that we want, and you can see that in comparison to the very first model you see with that overextended impression, you now have a record that really shows the closure space, which are the lateral aspects of how the tongue, the cheek is now able to keep the border of the denture in a stable and retentive position. And if we are lucky at all, do I press this to play? Let's see if this plays. And in some instances, I don't know if you heard the sound, but there was a very good a suction. In this case, it's not a guarantee. It is based on the anatomy presented, the rich form, the sponginess of the tissue, the shape of the retromolar area, how the tongue and the cheek comes together in that zone, and of course the mandibular control in the patient. But ideally, the final prosthesis, the reason why we are capturing a functional impression instead of a static is so that we can generate a prosthesis such that even as we get the patient to open and close within a reasonable range of movement, you can see how stable that denture is, and it does not get lifted by those musculature during these random movements. So we've spoken a lot about the mandibular impression, but I love this picture that has been shared to me by Steve McLean. To some of you who may know, he's a very, very lovely and very experienced prosthetist. But I like this image because with the different colors and material choice you use, you can then now visualize where are the areas that we want to selectively compress and where are the areas that we want to just capture with a flow in detail. Because once you are actually able to know, assess, and visualize what you want to take, then you will be able to capture it with your impression. It's visualization in a different way to your fixed pros, but still, it is the matter of whether you're able to see it and assess it and then be able to work out how to capture it. So thank you, Ben.
Oh, very well described, Agnes. And while we're on the topic of removable prosthesis, now there's also implant removable prosthesis. And Zoe, I know that you have a very slick technique and a very quick method to very quickly taking such impressions and fabricating an implant overdenture, so to speak.
Thank you, Ben. Thanks, Agnes. I think you covered that beautifully with the way that you take an impression. So again, with implant overdentures. So if we have a patient who presents with an implant overdenture, most commonly these patients will have some sort of a denture that they might not be fitting 100%, but it is there and it represents the correct OVD. And again, Agnes have showed you how you can look into the extensions and whether that denture is actually well fitting or not, and whether you need to modify it. So, so to cover quickly, if you don't want to start making a denture from scratch and you want to cut on some steps along the way, one way is to actually use that denture that the patient comes with and duplicate it into a provisional kind of a duplicate denture that you will use as a special tray. So the advantage of that is you've got some teeth, so we can utilize those teeth to record the MMR. At the same time as capturing the impression of the fitting surface of the denture. So now we've selected our locator abutments. They skewed in and torqued to the final torque. We go and put on our locator pickup copings. So these copings will stay on the locators, and now we can create enough spaces inside our special tray or the denture, we copy denture, so that circles that we perforated through it will go through without interfering with the denture seat. So you have to make sure, even sometimes you use a fit checker to ensure that there's actually no interferences. So when that's seated, it's got a circular free space around it, so there's no hitting or and there's enough space for the impression material to go through. So now we've got our special tray sitting in the mouth. So we follow exactly what Agnes have spoken to you about or showed you so beautifully in terms of making a denture from scratch. You put the adhesive on and use a polyether impression to capture that. So border molding, having the full extension of the denture, and then inside that you can see that we have also captured the pickup, the abutment pickups. So once that's done, you can utilize that same impression and use it to record your MMR. So now we've got the MMR, we've got the impression, all in the same appointments. So we've cut down on the MMR appointments. Now, once the lab has poured up the impression, they do have some sort of a guide on where the teeth are positioned, and they know the MMR. So now they can make some putty keys of that position and start setting up the teeth using the keys and the guides that we've recorded so far. So now you've got a denture that we're finishing, and we're happy and confident that it will fit in the mouth as it is in the model. So we go ahead and finish it, and that's the final result. So you've got a bit of staining and making it looking so beautiful. And it will be issued on the appointment. So we've managed to cut down a few sessions there.
Absolutely. Very, very slick technique indeed. One question from the audience asks, what's the torque value, I guess, of attaching the impression coping into the implant? Or do you have to torque it down? It will be just finger tightness, and that will be more than enough. So now we're coming towards the end of our session and the very last topic. it's on intraoral scanning or digital scanning, something that many clinicians already have adopted and already have a scanner in their office, creating a variety of different procedures, whether it's for restorative or orthodontics or any other, simply doing a smile design. So obviously the application is very wide. As we know, that digital scanning has been around for quite some time, since '87 when CEREC was first launched. Of course, it has now come a long way. Now these intra-oral scanners are so much smaller, portable, wireless, and much more accurate than what it was. Of course, we all know the advantages of scanning, which primarily is really cutting down your clinical time. Patients are feeling much more comfortable, none of that gooey stuff inside the mouth anymore. Fairly accurate, particularly in short spans, and I'll talk more about their accuracies or inaccuracies. And of course, it's a great marketing tool. Not only it really wows the patient with the technology that you have, but certainly you can create, say, digital smile design or any other types of digital mock-ups that you could do. There are, of course, a few disadvantages at the same time. Not only that these technologies are quite expensive initially, but often during the ongoing, for example, the tips and other bits and pieces, and also the licensing software in some brands. There's also, don't forget, the cost of the model that you have to print. With quite a few type of fixed prostheses, or implant prostheses, usually you need some sort of a resin model, and they don't come for free most of the time. And of course, the potential for certain inaccuracy. Now, one of the biggest type of inaccuracy is called a linear stitching error. Now, how that's come about is typically, now the operator would start on the occlusal surface from one tooth, typically it's 2-7 for most of the studies. Right, and then you go across the occlusal surface, across all the teeth, all the way to the other tooth, to the other side, say from 2-7 all the way to the 1-7. And then you go back and forth a few times to capture the buccal and then the palatal surfaces as well. And how this is turned into a digital image is stitching. So literally hundreds of photos are taken during this process, and which are digitally calculated and calibrated. And the algorithm will throw out the data that is inaccurate and keep the most consistent set of data. Now, notice I use the word consistent, not necessarily the most accurate. So now that they know how to stitch the things together, much like how your iPhone takes a panoramic picture, exactly the same concept. And once things are stitched together, now you form a full arch or a much bigger image, which looks pretty good to all of us. So let's take a look at some studies on showing this particular process and why errors exist. Now, this is a full mouth cadaver study. So they're using an intraoral scanner and also comparing, I think it was 6 different types of scanners, 7, but beg your pardon, types of scanners, and comparing the accuracy to a conventional impression of a full arch cadaver jaw. So they scan from one side of the mouth to the other side. So here on screen, you can see that on the left-hand side, that's a conventional impression, where there's green all around, which means that there's very little errors for all the teeth. Whereas the image on the right-hand side, it's done by an intraoral scanner, and as you can see, it's starting from the 2-7 as it goes across to the other side. There's more different colors other than green. There's some yellows, and then eventually towards the 6 and 7, lots of red, which means there's now inaccuracy. So errors starts to creep in the further you move away from the initial starting position, because how the computer algorithm works is that it's looking for most consistent set of data, not necessarily the most accurate, because these machines don't know what is accuracy. It just knows data. So if you scan an area that is inaccurate, say it's got saliva and bubbles and all sorts of things, or you've used a poor technique of scanning, but consistently doing so, so you now have a consistent set of inaccurate data. And the machine will take that into consideration, right? So eventually, what you find is that it's almost always towards the most distal unit from the other end that you get the greatest amount of vertical difference. So the image on the left, what you see is that the color in blue is the original tooth position, and the color in green is the actual scanned position. And this particular study looked at 2 points of every single tooth, and they started doing lots of measurements. And if you were to start plotting, looking at what the results they got and plot it into a graph, and what you typically see that linear progression from left to right. So as you scan the arch, the amount of error starts to introduce more and more and more and more and more on average. So towards the very end, near the 1/7 is usually where you get the greatest amount of error. When compared to the red dotted line all the way on the bottom, that is the conventional physical impression. And what you see is that every tooth literally has the same level of error, which is around 50 microns or so. Whereas with intraoral scanning, we're using, when they tested these particular scanners, which quite a few of these are fairly old, all of them have had errors, well, it is the final error sitting at above 200 microns, which in clinical dentistry is not considered clinically acceptable, particularly for implant dentistry, which has so much lesser margin of error. This study is perhaps a little bit more applicable to our current market. It was also introduced very recently. Again, looking at 6 intraoral scanners and 2 desktop or lab scanners. Of the intraoral scanners, you can see that they're testing Trios, Carestream, Metadite 500, and Prime Scan, right? Lots of good popular brands that we all know are excellent scanners out there. And so again, they operated this particular study, they scanned from 2/7 to 1/7, measuring all the teeth. But as a summary, we've only selected a few data sets just to make things a little bit more easier to understand. So in the next picture, what you're showing is that this data is showing you that of the error at the site 2/4, which indicates a 3-unit case, at the site 2/1, which is basically half an arch, and at 1/7 for a full arch. And you can see the data that they found for yourselves, that once again, similar to the last study, the further it deviates away from the initial position, the greater the error. And I've also highlighted in red colors, which is anything that's greater than 200. Again, clinically, it's considered unacceptable. So as a general rule of thumb, full arch intraoral scanning tends to have quite a bit of error. So you do have to be quite careful in doing that. And this is for these are for fully dentate arches as well, right? When there is a tooth to digitally stitch the pictures across. So if you have areas with missing teeth, or we're talking about dental implant full arch cases where there's a lot of soft tissue in between, then the error only goes up. Now for single teeth, these scanners are very accurate. For example, this particular study that compared the difference of marginal fit between for single tooth crowns or 3-unit bridges, and they found extremely comparable data. In fact, digital scanning appears to be even more accurate than conventional impression taking. So it's good to see that that level of accuracy exists, because you didn't need to scan the whole mouth, right, for that particular area. And when different, another article here, when it's looking at subgingival scanning, things take a slightly different toll. What we can see is that particularly when you go doing more than 1 millimeter, especially around that orange bar, which is the group that look at that's between 1.5 to 2 millimeter subgingival margins, the marginal gap of the final prosthesis to the crown, it's 0.96. Basically, it's a 1 millimeter in a gap, which means that is definitely not clinically acceptable. So hence, that's why the author for that particular article said, well, it's still not recommended for scanning if your crown prep basically margin is very deep subgingival. For implant dentistry, like I said earlier, the concept is very, very similar. It's very difficult to make conclusions about what you can and can't do, because the study heterogeneity is so different, and the scanning techniques are so different. Everyone scans differently. There's so many tips and tricks out there in scanning. Implants, there's, I'm sure on DPR, we've all seen those different battleships, basically larger scan bodies that you can put in place so that reduces the soft tissue space for you to scan. So, right, lots of different ways of scanning, and it's impossible for different studies to look at all the different techniques. But as at that study, that we can again show, if Brett could show it up on screen, what they've concluded, generally speaking, is that in very short sections, 1 to 2 teeth, definitely there is no difference between a conventional physical impression versus digital scanning. However, when you're going for fairly long spans, you have to exercise some caution. Perhaps you have to use a slightly different technique, or perhaps the best scanner that's around. And at the moment, generally speaking, scanning for full arch fixed implant prosthesis is still not recommended because of the degree of inaccuracies that exists. So hopefully that gives us some guide, but we know that technology is constantly improving, methods are constantly being developed, and things are becoming much better. So watch this space, and I'm sure we all look forward to better technologies to improve the lives of our patients. Couple of questions here. I think most of these for you, Zoe. I think here's an easy one. How do you get the clear copy denture tray again?
Okay, so how to copy a denture. So quickly in the chair while the patient is sitting, what you could do is pick an impression tray that the denture can sit in nicely, and then I'll just use a lap putty. So I'll put like a big blob of lap putty inside that tray, push the denture in it on one surface, wait for that to sit or set, and then Vaseline around that lap putty a lot, so it doesn't lock, doesn't adhere to the other layer of lap putty that goes on top, and then another big blob on top of it on the other fittings, on the other surface of the denture, without removing the denture, and then you'll have like a tray that's really covered with a lap putty.
Yes.
And then once that's set, take it off. You've got to give the denture to the back of the patient, and what you have is a space where that denture was. And then you can use like a clear, self-curing, a clear acrylic to flow into the space and hold it together, and then pressure cook it for a bit. And you've got that tray.
Yeah.
And I think, like, what you so explicitly said, for those who are trying to do this in their own time, probably a few tips is only as accurate as your handling. So essentially, you're making a two-part mold with your putty. So how closely you approximate, or how well the details you capture as you push that denture in, you may actually very well reline the details if you want it to be nice and detailed and smooth for the patient comfort. You can use either fit checker or a light body PVS to line for the detail, and you must make sure that the two pieces come together well. And as you make the acrylic copy denture, I think Zoe is really good at mentioning to let it set under pressure. But ideally, these are work that is being done at least maybe the day before, because as we all know, like, the acrylic does take some time to set. Certainly you don't want to be doing this and then taking it to the mouth, because there will be some shrinkage that might occur. So and I think the other thing I like to add on to those, only if you were interested or paid attention, when Zoe then repeated the technique using a copy denture to pick up the impression coping of the locators and do a wash over the ridge area, she really have actually trimmed down the intaglio surface of that denture to create the space. And I think polyether was a great choice because it can be both mucocompressive as well as mucostatic. It is an excellent property within the polyether itself, and because it's set so rigid, so it's a great pickup coping material as well, all at the same time. And and despite we really just using the clear acrylic as a framework. So as you then using it to capture the OVD, etc., you cannot just assume that the teeth are exactly where they are. You do then have to still pay attention to whether the centric or the OVD are still in the ideal places that you want to capture, and if there are any near misses, you're able to correct this information during your MMR or remark the midline, etc., to communicate across. But there are still valuable elements in that copy denture in terms of, that was the mold of teeth that the patient is used to, etc., etc. So it gives you flexibility in that way.
Absolutely. And one of the final questions, Zoe, is do you, when you take your impression with the locator impression copings, do you put a wire and then use incompetent and stabilize, basically splint the impression copings? I guess this question is about concern of when the denture is made, there is some sort of inaccuracies where the dentures is not fitted into the mouth. So therefore, should you be splinting these close tray impression copings during the impression stage?
Well, not really. For solitary implants, if the final design of the prosthesis is not to have a splinted bar or some sort of restoration of that sort, then with locators, you just take them individually without needing to splint, and the locator coping will have enough undercuts designed into it to lock into your rigid material. So you really don't need to worry about it. If the impression is accurate, then it should be fine to fit in the mouth.
I've even heard of prosthodontists having issues with this, that they actually do splint it. But during the impression taking stage, there's so many different steps. So without knowing all the different steps, it is hard to know where maybe those inaccuracies took place. I guess there's nothing wrong with splinting them should you choose to. So at least you've eliminated that this error did not occur during that impression stage. Then maybe some other different stages. But I think the reason why this particular technique for our team has worked so well is because we do take the time to adjust that special tray so that there is no pressure onto the impression coping and using a fairly rigid material when we took the impression. So therefore everything is quite rigid and it's locked in place.
And I guess we don't have enough space as well between our trays fitting on that space between the two implants almost on the tissues, that there's no real...
For that technique, I think you will have to use a different special tray of some sort to give you more space to do that.
Tray.
I do find once you have a sufficient material to lock in your impression coping, then usually that becomes very sturdy. But only when you have thin material, then you get a little distortion.
Maybe using like a light body PVS and the things can move a little bit, then definitely
and then you
possible.
get deformation. Or the other one would be some of the cases where they were fixed before, implants not in ideal position, but they are 6 implants. So they're not indicated originally had implants, so that they're not indicated for fixed cases. Where duplicate denture doesn't work because with 6 locators I've done in the past, where when you remove, one will distort anyway. So that one still goes for the traditional.
They weren't parallel, right? So some of the implants are in some interesting angles.
So basically, when I try to take that duplicate denture impression out, one of the locator will definitely move. So anything more than 4 or any 5 or 6 is just traditional. And I prefer putty key for those cases. Putty and then a light body combination. A little bit more rigid.
Going for rigidity again. Okay. Very good tip. So as we getting towards the end of this session, any concluding remarks, any summaries?
I think my
Agnes?
concluding remark is very predictable, which is what I've said for the 3rd time tonight. If you can, it's very important to be able to visualize what you're trying to capture. And I think if you know what you're aiming and you can see clinically what you're trying to capture, then you'll be able to get a nice impression of it.
Absolutely. Johnson?
I think like for two-step impression or impression is important to plan. If you know there is going to be a challenging case, or who's going to bleed or multi-unit, just allow a little bit more time. Could be 15 minutes, could
Don't
be half
rush.
an hour more. So you don't have to rush, because two-step does take a little bit more time.
For sure. Zoe?
Yeah, I think time is the main thing. So if you're rushing throughout the appointment, everything seems to go wrong.
For sure.
Allow enough space. Have a good assistant to assist, or maybe two assistants to help you out through the procedure.
Yes.
That will make life a lot easier.
Yeah, definitely. Work within your comfort zone and your own I guess limitation. There's another technique, I guess, when you're working multi units. I think there was another case that we couldn't show tonight because of time limitation. Was that you've it's again as a 4-arch case where you actually split them up into segments.
Absolutely.
You've actually completed the anterior first, and then you complete one segment at a time.
Absolutely. You don't have to do everything together.
No. So a couple of units at a time, and that's
and sometimes
terrific.
patients prefer that
Yes.
doing in segments as well. So I think I have to just determine a flow that suits yourself as well as the patient.
Yes, as opposed to going through an iron jaw challenge to see how long you can keep a jaw open for your favorite dentist. Well, thank you so much, team. I deeply appreciate your time and effort towards this, and thank you so much, ladies and gentlemen, for tuning in tonight. We had a blast sharing what we've known, what we learned.
Thank you for all the engagement and all the questions.
Absolutely.
That was really, really nice for us to have that. Thank you.
People are even joining us from Tehran, saying hi. So thank you for joining us, and thank you for your eternal support and trust in us to look after your patients. Without your support, we would simply cease to exist. So thank you on behalf of the team. And also, once again, just a reminder for those of you who is looking for your CPE certificate, please don't forget to scroll down to the bottom to enter your name and email address. Thank you once again for joining us tonight. We look forward to seeing you again at our next webinar. For now, it's good night.